Good evening, friends. We are meeting for a landmark event of the IAGES. It's two eminent legends of laparoscopic surgery. We are going to listen to their wisdom. We are going to listen their thought sharing. And I'm sure our lives are going to be a fresh and a changed one. And how we look at our life is going to change forever at the end of this program. I thank IAGES for giving me this opportunity to convene this session. I thank our President, Dr. Aman Goyal, for creating this concept and giving us the permissions to proceed with this required faculty. We also have the presidents of the Society of Endolaparoscopic Society of Bangladesh and the Pakistan Surgical Society going to join us shortly. Now, I take privilege of inviting Professor Pavaninder Lal, the direct student of Professor Alfred Crucieri, albeit 35 years before or 33 years before, but still their relationship is something amazing, commendable, and they enjoy a perfect professional relationship of a teacher-student relationship. To briefly tell people who are watching out of the country, Professor Pavaninder Lal is the Executive Director of the National Board of the Examinations, the topmost exam authority and the training authority of medical education in India. He is also the Director Professor of the Department of General Surgery at Maulana Azad Medical College. And he also is the head of the Minimal Access Surgical Skills Center at the Maulana Azad Medical College, amidst multiple positions what he is holding. Now I take privilege in inviting Professor Pavaninder Lal to invite his teacher, Sir Alfred Crucieri, sir, to all of us. Pavaninder Lal, sir, please.
Very good evening, Dr. Kanagavel, and thank you for this very kind introduction and this very kind opportunity. It gives me a great privilege and honor to welcome my mentor and mentor to thousands of laparoscopic surgeons of the world, none other than the pioneer, Professor Sir Alfred Crucieri, a surgeon innovator, a teacher, a mentor, and leader in the true sense of the words. Professor Crucieri hails from Malta, and he completed his medical degree from University of Malta in 1961. Soon after, he left for the UK to undertake further research at the University of Liverpool, and soon rose from a lecturer position to having a personal chair in surgery in the year 1974. 2 years later, in 1976, Professor Crucieri moved to the University of Dundee and the Nine Wells Hospital, where he established and became the professor of surgery and the chairman of the molecular oncology department. It would not be wrong to say that Nine Wells Hospital and Dundee in Scotland and the famous Tayside laparoscopic extracorporeal knot all got world famous due to the landmark research and innovation carried out by Professor Crucieri, and for laparoscopy, all roads in the world at that time led to Dundee. Professor Crucieri trained an ordinary person like me and thousands others and inspired an equal number to take up minimal access surgery as their careers. More than 25 of his students have held professorial chairs across the globe. On the road while developing this specialty, Professor Crucieri received honorary fellowships of several international organizations, Moynihan Prize from Association of Surgeons of Great Britain and Ireland, Ernest Miles Medal, and was conferred the knighthood by Her Majesty the Queen in the year 1998. He has also received gold medal and the President's Medal from the Royal College of Surgeons of Edinburgh. His innovations can be judged by the fact that he holds 58 patents for various surgical instruments, majority of which go by his name. He has been the founder, European editor-in-chief of the famous laparoscopic journal Surgical Endoscopy since 1992. And I'm particularly delighted to inform you all that the current editor-in-chief of Surgical Endoscopy, Professor George Hanna, completed his PhD in ergonomics in laparoscopic surgery from Dundee under the tutelage of Professor Crucieri in the same year when I was with Professor. He has been the professor of surgery at the Scuola Superior Sant'Anna since 2003 and is currently the Senior Scientific Advisor and Principal Investigator, Surgical Technology and Robotics Group for the Institute for Medical and Technology, IMSAT, at the University of Dundee, and is actively engaged in the future dimensions of laparoscopic surgery. Ladies and gentlemen, on this historic day of the prime time event of the Indian Association of Gastrointestinal and Endoscopic Surgeons, it gives me a great pleasure to welcome and present to you the one and only Sir Professor Alfred Kusheri.
Professor
Thank you
Kusheri.
very much, Dr. Lal, Professor Lal. You are most kind to me.
Professor
Sir,
Kusheri,
you can
please share your
please share your screen and you can start your presentation and your talk, sir.
Can you see it?
Not yet, sir. You just have to press the green button, the share screen button, and then again select the.
So you will have to click on the screen once and then select the share button again.
I know. That's what I'm trying to do.
You need to then select the share again. So you got to share it 2 times.
Yes.
Now, so Dr. Pavninda, between 2 shares, he will have to click on the screen once.
Yeah,
Yeah.
That's got it. Yes, it's coming, sir. It's coming now. So you can go down to the PowerPoint, sir. Yes, that's right.
Can you see it now?
Perfectly clear.
Okay. Thank you very much. Thank you very much. It is a great honor for me to be invited to give this keynote lecture at this Congress of IAGES. And I remember very much the day when Professor Devendra Dudwania invited me to the opening of the new association he founded for India, the Indian Association of Laparoscopic and Gastrointestinal Surgeons, IAGES. You will notice that I use the term not minimally invasive surgery in my talk, although this is the accepted widespread use throughout the world. And I don't challenge that. But I do believe that the purpose of the new surgical approach arose in my experience as a means of reducing the trauma of access. Because when I was arrested in Liverpool, many of the elderly patients had huge incisions from xiphoid to symphysis pubis, such that post-operatively, this is in the late 1960s, post-operative, most of the elderly people died of pneumonia because they couldn't breathe, and pain relief was not good in those days. Hence my preference for minimal access surgery. And the difference between open surgery and minimal access surgery, or minimally invasive surgery, as it's generally called, is shown in this slide. In open surgery, the access trauma to the patient, the big incision, forms most of the traumatic insult to the patient, whereas in mass it's reversed. Of course, it has one downside, irrespective of the name we call it, of this new approach, in that it reduces the degrees of freedom possible by the surgeon operating through a port to 4 degrees, and hence increases the execution difficulty of all operations. And we'll come back to that later on. In this slide, I show the first large reported European series published in the American Journal of Surgery on from the register we had formed from the French and German surgeons on the first 1,200 cases or so of laparoscopic cholecystectomy. Can you hear me?
Very well, sir.
Yes, you can hear me. Okay, and this really was remarkable for a first-time operation. There were no operative deaths. We had to convert the 45 patients either because of technical difficulty or the onset of complication, or in one case, instrument failure. We had no deaths, and the total post-operative complication rate was quite respectable, as you can see. Immediate hospital stay was 3 days, with a range of 1 to 27 days. And we felt that, therefore, this was a safe operation and ready for introduction with some control. So what happened? The initial outcome worldwide, I'm talking about the periods between 1988 and 2001. It was, ladies and gentlemen, an unmitigated disaster everywhere. In the Jerry Marks lecture at SAGES, I referred to it as the greatest free-for-all in the history of surgery. It was characterized by a surge of operative on-table deaths, most often from exsanguination, and a significant increase in iatrogenic injuries, exemplified by serious damage to the biliary, extrahepatic biliary tract, with 2 to 4-fold increase in these major bile duct thickeners. Some, about 5.5% were lethal, fatal, and others, believe it or not, required hepatic transplantation because there were combined biliary and vascular strictures. Some patients were, fortunately for me and the innovators, relatives of highly influential people who actually died on the table. And when you damage or kill somebody who was related to the people in power, that's when the country hears what you say. And in many ways, good came out of these disasters by that means. So, reasons for why did this happen? When I look back, there were multiple compounding factors. The new surgical approach in the first one was not initially approved, certainly in the UK and in France, by the majority of academic influential centers. So it was a peripheral development in the first couple of years, taken up by District General Hospital without credentials and without audit. The pioneers included myself, edited videos of procedures for training. This was my greatest error of judgment, because it made it look to the onlookers that these operations were easy, faultless. Okay, that was the biggest training mistake I've ever did in my life. And myself and Abe Fingerhut, one of the French surgeons involved in the early years, wrote an editorial in surgical endoscopies, and we should stop editing videos. As trainers, we should do not commend this as good practice. If you do operation, you record all of it and show all of it, warts and all. If we did, there's nothing, not so much damage. Importance of early as opposed to enforced decision to convert because of either lack of progress usually, wasn't stressed enough in my view in those days. And elective conversion to operation, to open surgery, does not disadvantage the patient. But enforced conversion because of the onset of major bleeding or major complication to bowel or bile duct or whatever is undoubtedly followed by a bad outcome as far as patients are concerned. So that's important. And the reason for early conversion, when in trouble for any reason whatsoever, before inflicting iatrogenic damage, wasn't stressed enough in my view. So how was it resolved, this period of tragic iatrogenic injury, almost of epidemic proportion? We had, at the time, no regulations in existence anywhere in the world relating to credentialing and privilege system in place, and that includes the US of A. And when that came in, it changed the scene considerably. But the problem, in my opinion, was resolved by the establishment of surgical skills unit. Because in the UK, I don't know elsewhere, but in the UK, one of the patients who died on the table was a relative of a very important member of the House of Lords, Lord Wilson, very rich guy, very great altruist, who absolutely drew this to the government's attention and brought it into the public. And because he was in authority in the House of Lords, and because he also was a very rich man and a great altruist, I have to say, he said to the government, I'll give 15 million if the DHS says that the government doubles that to set up skills training programs for this new surgical approach. And Professor Tawad, the skills unit was established in October 1992 and became the template for training centers in the UK and overseas. And Prof attempted to establish at similar time, similar training centers also funded by industry, as was mine, by stored in my case also by US Surgical, as it was called then in America. In the UK, national training programs were well established and funded in 3 UK surgical colleges and 4 major national centres, Dundee, Leeds, London and Guildford. And this is essential because I have to tell you, we cannot rely anymore on industrial funding. That those days are gone. Either we or the government or someone has to fund these. If we want, and we would save a lot of money, and there's a lot of lives as well. We have progressed, and the surgical skills unit now uses, which was established, as I said, a long time ago, for the promotion of safe minimal access surgery and training of other skills. But since the millennium, we have started using teal, soft and balm human cadavers. In the UK, one can make a living will. There's legislation for that. So I could leave my body when I die within 24 hours to go to a university teaching hospital for training or research. And that's called a living will. And is approved by the legislation of the land. Professor Teal, 25 years previously, had developed soft embalming, which preserve the human body intact as if it is alive. You can make these corpses breathe by attaching them to ventilators and have a blood pressure if you want, by attaching them to an extracorporeal pump. The tissues are like, they look like alive in color, skin elasticity, turgor, everything. And we can now practice, as you can see this slide, this is a course on upper GI advanced gastrectomy, esophagectomy, colorectal, vascular, anything, using whole operations. We get 100 such donations in Scotland every year by these generous people. We have to observe the religion of the individual, because the body under the legislation is looked after, responsibility of the university. And at the end of its use for courses and training, etc., it is buried by the university according to religion and desires outlined in the will of the individual. I introduced this to China, and China have liked it so much they now far ahead of us in having this major process of requesting living will by people, particularly in Nanjing. It's incredible how it works. So this simple operation has virtually transformed surgery in all its specialties, including transplant surgery, specifically living-related transplantation of kidneys and split livers, which has been a tremendous advance in patients with diabetes, with pancreas and kidney failure, and also in other conditions. We had a period where the precursors of what is now the future, I think, advanced endoluminal surgery. The two opposing factions were nodes largely initiated in India, I should to say, and single port laparoscopic surgery. Both were good and both had defects as well, but they stimulated the trend towards reducing the trauma of access to the development of advanced endoluminal surgery, which is increasing in the practice, and of course is the least traumatic of all. Nowadays, the poem for achalasia is incredible by those who do it, and we need to consider this. In other words, this will reflect on the training surgical curriculum And in my view, surgeons have to learn flexible endoscopy. They mustn't leave it to the gastroenterologist. It has transformed operative surgical practice. Why? Because bad technical surgery is there to be witnessed. The importance of tissue planes was documented by the 4K high-resolution imaging possible with the advancing technology. It was a major benefit to safe, oncologically curative RO surgery for intra-abdominal cancers. Its own right promoted endosurgeon-guided radical RO, potentially curative resections for cancer as well, which documented on clinical trials improvement in the 5-year survival rate after pathologically confirmed potentially curative resections. And the new millennium, the kinematic restriction I referred to at the start, imposed on the operating surgeon by the mass approach, was overcome by the introduction of robotic-assisted laparoscopic surgery. It is not robotic surgery, ladies and gentlemen. It is robotic-assisted surgery. The surgeon is still in charge. This idea, I'm a specialist robotic surgeon, is for the birds. This is an example of the development further of robotic surgery. It is robotic surgery with augmented reality. And it consists of patient information from a CT or MRI is segmented with 3D reconstruction of the topographical anatomy, exact location and anatomical relationship of the tumor to surrounding structures, etc. This is followed by image registration with the anesthetized patients in the operating room using patient tracking system, of which there are several types. The surgeon has a special helmet which enables augmented image to be projected onto the patient to guide the surgeon in difficult cases. And I want to show you, if I can get rid of this. Okay, if I can show you this video. This is from Endocast, which I set up in there. This is a lady, 32, with an aneurysm of the splenic artery. This has been segmented. And as you can see, this is her aneurysm. This aneurysm will burst and kill 100% these patients. We've segmented it, and the surgeon isn't here. These helmets now are much lighter, better. This is 15 years old. And this is, he is projecting this, what you see, onto the patient, registering with the patient. And you can see as he moves in, close to the tummy, he can actually, that's what he's seeing, and that's the anatomy. And he can guide, because in doing this aneurysm and tying all the vessels, bar one, the continuity of which has to be preserved. Otherwise, the spleen will necrose. Okay? Now, the model is active. In other words, it can tell him by him referring which vessels can be tied and which vessels can't be tied. Because he keeps referring to this, as you can see, and the algorithm tells him, yes, you can clip or tie whatever, or no, you have to preserve. And there's usually one vessel, and it varies in an aneurysm because it has about 7 or 8 branches feeding it. Okay, which one can be divided, but there is one vessel that has to be preserved. And this is identified by this. I mean, this is now, as you can see, we can see what will happen. And it says that this vessel has to be anastomosed. This is the vessel that will determine the viability of the spleen. Otherwise, you will have to do a splenectomy, which in a young person is not a good thing. And this is followed by anastomosis. And because of the robot, of course, the anastomosis, despite being sort of a small, relatively small, this is a 4 millimeter artery that it will preserving. The robot makes it look easy, really. I mean, make it sound like he is a super surgeon, you know, but superhuman surgeon. But it's not. It's just the flexibility it provides is important. And when this is done and finished, okay, you can see that it's pulsating. We'll get an ultrasound probe, laparoscopic, to check that this, you see where it was blue, dark, we're following it and seeing that the pulsations are returning. Okay, that's important. Now that will be okay. And now we can open we can aspirate the aneurysm and just leave it to shrivel, basically. So I now come to a favorite topic of mine, surgical training, which we need because surgery is a craft profession. You can be a walking encyclopedia, but if you can't operate, you should be a physician, but not a surgeon. And we've had problems with surgical training. I call them unresolved issues. The first I would highlight is criteria for admission of candidates to recognize surgical training. All the admissions selection are based on what they've achieved in school, in high school, and university, undergraduate, all right? In other words, their cognitive ability. It doesn't take account of, has this individual the necessary coordination of his hands to do surgery? Has he got the light touch? Has he got the visual spatial ability? Now, dentists have used this for 20 years. You cannot enter a dental school in the UK unless you do an exercise on a model and pass it. It doesn't have to be virtual reality. So that's important. I think we need not just select on basic cognitive skill and track record in examinations at school and medical college. That's not enough. That's important, don't get me wrong, but not enough. We need to establish that the trainee selected for the grade is coordinated, has the visual spatial ability. The second issue is lack of revision of surgical training curriculum to reflect the changes in surgical practice imposed by the new surgical approaches. What we do nowadays is nothing that I learned when I was at medical school at all. There's a complete absence of any documented competence-based surgical training. I want to know not how long the training program is 5, 4, 6 years, but are the trainees, have they reached competence by the time they finish? That I call competence-based curriculum. And for this, flexible training curriculum is needed to match the individually different innate aptitude for psychomotor skills of surgical trainees. And I think it's important increasingly in the bigger training programs to have access to advanced virtual reality simulators, which really, I believe, are very important in the skills acquisition. Because when an individual, Lord Moynihan used to say, the hand of the beginner is heavy. And basically what he's saying is, he is passing for a phase of controlled conscious processing. The beginner requires attention control. It shows slow and deliberate execution and tires, is subject to fatigue. As he acquires proficiency, he passes on to the automatic, unconscious process. The wiring has happened in the subthalamic region, this is basal ganglia region. Circuits are established, and all it is cerebral cortex telling him, do this colectomy laparoscopically, and he doesn't even need to think about it. It's effortless, intuitive, and fast, and not mentally exhausting. This is at the end of the study on 250 in Italy, in my center, 250 trainees over a 10-year period, time to proficiency. How long it took them. And you can see this bell-shaped grade. Now, when you look at this in particular, it's this end that matters, and this end that matters, in my view, because the majority are fine. And when you break these up, what you have is a very small percentage of extraordinarily able guys. You show him to do the operation, and after 3 or 4, he can do it as well as you can. Then there is the big average. And there are a larger group who really struggle, and in my opinion, are not suitable for a career in surgery and should be identified and advised early on in training. And this has led me up to what I call proficiency gain curves. The literature writes and indicates or learning curves. Learning curve of an operation is knowing the steps and sequences of an operation. It does not mean that you can do the operation. Proficiency is required by an individual doing an operation, having established the component steps and the order, assisted by a mentor, for the time to reach his ability of the safe zone, proficiency zone, accepted by society as the outcome most competent surgeons produce. And it's a bad, really, because some are better than others. But you must read, and most trainees, 80%, with number of cases performed under super, reach this green proficiency zone. A few, the naturally gifted with innate aptitude, require much less. We all know these people. We all know. And these are the gifted surgeons, the ones who become master surgeons. There are unfortunately those who never will reach proficiency zone. Never. And there are others who lose, initially gain it, and then lose it. And the reasons for this is usually disease. Very often in the UK, it's alcohol or some form of addiction. And to me, this indicates the importance of reappraisal and revalidation of surgeons during their lifetime of work. So what has been the impact of minimal access surgery or minimally invasive surgery? Has had a profound positive impact on the surgical care of our patients. Remember, they are our patients. We are responsible for that. Reduction in blood transfusion, very little pain, fast recovery, low wound complication, virtually non-existing, less adhesions. So with a new era of evidence-based and not eminence-based surgery, it changed practice in patients undergoing open major surgery, including fast-track protocols, virtual abolition of prophylactic nasogastric junction, and new clinical endpoints on patients' outcome. PROMs, patients-reported outcome measures. In the UK, in addition to the discharge note, we have the reports from patients as to how were they treated in their stay in hospital for the time of admission to discharge, and very other parameters. Surgical trainers now recognize the need for changes in surgical training curricula, and we need to collectively work towards this objective. Establishment of skills training labs are essential, as is, in my view, surgical simulation. Could we have introduced this disruptive surgical approach better? The answer is yes. And the mayhem with the introduction of mass or minimal invasive surgery avoided with far fewer lost lives and harmed patients, some of whom died of their injuries, and many required major remedial operations. In many countries, including the UK, we delayed the introduction of credentialing and privileging based on expected national standards of expected outcome after all various operations across all surgical specialties. We are late in revising selection of candidates for entrance to approved national surgical training programs. And to revise the training curriculum, this has been long overdue. We have demonstrably failed to look to the future requirements for training. The emergence of what I call minimal access therapy, MAT, by disease-related treatment groups, DRGs, as they are being called, consisting of the three arms: interventional endoscopists, interventional radiologists, and surgeons, mass and open. Surgeons have to lead these DRGs, as we as surgeons will always provide the remedial treatment necessary when patients' outcome is jeopardized for whatever reason. I want to end by showing you something that has taken me a long time to develop, 20 years of research in association with visual psychologists. And we have shown by several publications, I don't have time to go into detail, that both task efficiency, how long it takes you to do an operation, and task quality, based on outcome, experimentally in animals, in pig, large operations in the pigs, are obtained when the operating surgeons look down so that that he or she can see his or her hands. In this system, the image is not viewed on a remote television monitor. Instead, the image is projected on the stainless steel screen on top of the patient's chest and the middle of the surgeon's hands. This is the role plane described by Kennedy and Wade, and which I have taken up. The screen with the projected image is located directly in front and below the head of the operating surgeon, enabling gaze down frontal viewing. This is what the watchmakers do. They see their hands. If you want to be very fine work, you have to see your hands. Imagine eating without seeing the fork entering your mouth. Hands of the surgeons are in the same plane as the image. The image is close to the actual operating site, reduces this, what the visual psychologists call the cerebral mapping problem. So I then deal with this slide. This is me, aged 65, 30th of September 2003, when we have to retire. I reluctantly, there was not going to be an exception. This is the operation, laparoscopic gastrectomy performed with this gaze-down imaging. At that time, we had to make special screen, which was problematic but worked. And I completed this in my last operation at 9 wells, laparoscopic radical gastrectomy with this approach. And now we can have 4K resolution OLEDs. And I'm working with LG to have this. It's very cheap, great low energy uses, wide viewing angle, etc. And I'm really looking forward to taking this forward in the future. And I hope people will realize its importance. Ladies and gentlemen, thank you for inviting me to this virtual IAGES Congress and for listening to me. I am truly honored. Thank you.
Thank you very much, Prof. That was just amazing. That was really your true self opening up in front of us and telling your journey from how you started and how you learned your lessons and how open you have been to technology and to the fact that you are so keen in considering the training aspect of surgeons, how you could improve training and how you have learned over a time what mistakes happened and how we could correct. And it's just also an eye-opener to all of us and to all the audience today that how futuristic you are, how out of the box you have been. And if it was not that cerebral portion in your mind, you would not have been, and we would not have reached.
You are most kind.
So it's just, it was just really amazing talk. Thank you very much, Prof. And there have been some very interesting questions. And with your permission, we will have a few of them. We have been a bit late, so we need to put our interview as well. So we would start with the first one, which is on which is a very interesting question, that are we going overboard by trying to do every type of intra-abdominal procedure by the minimally invasive surgery technique, even at the cost of safety and complications? And do you think there is a need to strike a balance between safety to the patients and the surgical environment and achievement?
I couldn't agree with the person who put that question more. Foremost in our minds as responsible human surgeons, the safety of the people we operate is of paramount, comes first. And this is why I don't understand, even if they're doing an operation, and it's difficult, and it's not going anywhere, there's no program, what the hell persist for? I don't believe in enforced conversion. I believe in elective conversion. That's what common sense tells me. If I'm a surgeon who takes good care of his patients, the patient is an inside, he cannot object at the time you make that decision to continue. I'm sure if he could hear you say, stop it. You know, it's, to me, it's the height of it. It's illogical. I cannot understand. And I feel much better. I mean, there's no loss of faith. It couldn't be done. On that day, it couldn't be done for whatever reason laparoscopically.
Well said. Thank you, Professor. I'll request Dr. Kanagavel to come with the second one.
It was simply thought-provoking. Thank you, Professor Kusheri, for a wonderful viewpoint about what has been existing and what is the future, which all of us young surgeons are foreseeing. Thank you for a wonderful lecture.
Thank you.
And as a convener of this program, there are a few questions which are coming in. And we have Dr. Raman Goel, President of IAGES, joining us. And one of the questions from the participant is, Professor, minimization methods of common bile duct injury during laparoscopic cholecystectomy, particularly when a new young surgeon is performing his first 100 cases. What are the safety measures a young surgeon should keep in his mind?
In my view, if one takes his time in careful dissection and identification of the structures in the egg triangle of color, identify without any doubt the cystic duct, the common hepatic duct, the bile duct, bearing in mind that the cystic duct is so variable in its insertion. So many times I've done about over 80 bile duct remedial operations, and each time I insist on the video, and you can tell when the injured, because they weren't exposing the anatomy as it should be exposed, and they mistake the common hepatic duct for the cystic duct. You see, sometimes the cystic duct is quite big. Usually it's very small, but if there are stones in there, the cystic duct may be very big. So identification. I also teach, I have to say, but this is practiced only in Dundee as far as I can make out. We do an operative cholangiogram always. Now I know it takes another 5-10 minutes with an image intensifier. But my point is this. If you tell me I use it in difficult cases, you never learn how to use it, how to do it. So it's a waste of time if you have to do it. Whereas if you do it all the time, routine, we add up no more than 5 minutes to the operating time. And we have the biliary outline. We know we're okay. The other thing I would guard against, in my view, is not to put metal clips to close the cystic duct. Either put absorbable clips or tie, in my view. Because there's been so many cases with collar joints after where the metal clip is internalized in the common bile duct and form like what is known as a cat's eye stone. I've seen quite a number of those.
Thank you, Professor. Dr. Lal, please.
Prof, there is a very interesting question from a surgeon who is, and it could be from many. They are proficient surgeons who are now in their late 40s or mid 50s, doing all types of good quality open surgery. They want your advice whether it is too late for them to start minimal access surgery, and if it is not, how do they go about doing it?
I don't think it's if a good surgeon with a good track record is a dexterous person with visual spatial ability. If he really wants to, provided he takes the trouble of being mentored, all right, so that he can't have a go. There's no question of have a go. I'm a good trained surgeon. But there's no reason why, if he's had a good track surgeon as a dexter, it's the same qualities are needed, but the approach is different. He has to train to do it. By that time, in this case, get somebody with experience doing some cases with him.
In your experience, Prof, did you find ever very average or low quality open surgeons being very good laparoscopically, or the vice versa?
Never. Very bad surgeons are always bad, whether endoscopic, laparoscopic, or open. And we all know them. All right. The problem is this. We let them practice. And I personally, that has stopped in the UK now. Recently, 2 surgeons have been sent to prison in the UK. Both vascular surgeons, because they were warned not to operate. Their privileges were withdrawn, and they they damaged patients. And one of them has spent a year in prison, manslaughter. So basically, this is serious. If you can't do it, you shouldn't do it. Simple.
Well said. Well said. Dr. Kanagavel for the last one.
Yes. Professor Kusher, there is a question. Is the index of conversion a decision for the patient's safety or failure of the surgeon in laparoscopic surgery?
I do not see it as a failure. I see it as an exercise of good judgment. On that day, that particular surgeon decided, presume we're talking about a proficient surgeon, decided on that day, for whatever reason, he decided to convert. It's not, conversion is not a sign of failure. I mean, that's the worst possible interpretation of good surgical practice. Now, if somebody converts electively all his cases, then he needs training. But if the elective conversion rate, which varies in your lifetime, I mean, I converted at the very start, probably about in the first year of my about 4 to 5%. And towards the end, I hardly ever converted because it reflects experience and proficiency. Okay, so your elective conversion, I am happy to say, I have never been forced to convert because of subdural bleeding. or some major damage to blood vessel, whatever, or bile duct or whatever. Never. Why? Because if I wasn't making that golden 20 minutes, it's called, somebody, I can't remember the name they called it, what the American called it, golden period, where obviously you're messing about, you're making no progress, going from one end to the other, and no economy of movement, no progress. That's when you say, that's when you convert. And if you do that, you will never harm patients. We are not in the business of inflicting iatrogenic injuries. That's anathema to a good surgeon. A good surgeon takes good care of his patients on there. Good care means avoiding harming them.
Thank you, Professor Kusheri. We have lots of questions coming up, but then everyone is very eager to listen to the interview of the talk between you and Professor Udwadia. So now I hand over to our president and formally thank you, Professor Kusheri sir, and my co-convener, Professor Pavanindalal sir, for hosting this program with Professor Kusheri. Thank you, IAGS. Thank you, President. We now hand over to you, Professor Dr. Aman Goy.
Why?
Sir, mute, sir. You're in mute, sir.
You're muted, sir. And thank you, Prof.
My pleasure.
Good evening, Professor Kusheri.
Good evening to you, sir.
It's a privilege to welcome you in IAGS. You are a pioneer in lap surgery and also an honorary member of IAGS, which is a privilege for us. It was exciting to even consider that we can invite you and hear from you on this platform, which was initiated by Dr. Kanagvel almost about 2 months back. And you had been in forefront of MIS development right from the beginning. At the time when we were just learning to start laparoscopic surgery in early 90s, you had already published a series of 1,200 cases, which is an eye-opener. And when it was agreed that you have agreed to come to our meeting, then we started discussing who will be the right person to talk to you. And the unanimous choice was Professor Tenton Udwadia, your old friend who knew you so well. And that thought also came from Dr. Kanagvel that we should ask Professor Udwadia. And I was asked to speak to him. And I was pleasantly surprised that he not only immediately agreed, he said this is the way it should be done. And he will be very happy to talk to you about about the developments in last 30 years. I had the privilege to listen to your entire conversation, which we are going to share on the IAGS YouTube channel for all the members who are logged in today and who can hear later on. Your today's presentation was exemplary for its subjective focus and honest opinion. We all have been taking talks for years, decades now, and what I learned in the art of speaking and your focus and being so modern, showing the future of surgery to surgeons who are into it is a great learning. I think the IAGS leadership, especially the fellowship boards, we have 3 fellowship boards on their conveners will have to really listen to your talk again and learn from it. How do we identify the right candidate for training? How do we evaluate them? And how do we make our curriculum more flexible so that each person who is going out is a well-trained surgeon and only then he gets his fellowship certification? Professor Kusheri, we are very honored that besides IAGS, the Surgical Association of Bangladesh and Surgical Association of Pakistan, in their first time, they agreed to endorse an event of IAGS. And Dr. Sardar Naeem, who is president of Bangladesh Surgical Association, is actually here in the meeting room to say hello to you.
Nice to see you again.
Yeah, good to see you again, sir.
Yeah.
So, Professor Naeem, please go ahead.
Yeah. Okay. Thank you. Thank you. It was a great privilege to be here with Professor Alfred Kusheri, the father of modern surgery. I call him the father of modern surgery. The generations actually learn from him. And actually, this is a great honor to be able to show my deep gratitude to these two living legends, Professor Themten Udadia and Professor Alfred Kusheri. And actually, it is my proud privilege to know both these giants of surgery in person and being in touch with them from 1991, when I had the opportunity to perform my first laparoscopic surgery in Bangladesh. At this auspicious moment, definitely, I want to remember and I want to show my deep respect to Professor Yasuo Idezuki, my mentor, the late Professor Yasuo Idezuki, who was a friend of Professor Kusheri, as well as Professor Udadia. And he was very, very great personality. And I met Professor Kusheri in presence of him back in early 90s.
It was a lovely, lovely
as the
night
president,
there.
on behalf of society, yeah. And actually, I take this opportunity to congratulate Dr. Raman Goel from my society, the Society of Endolaparoscopic Surgeons of Bangladesh, to give us the opportunity to be a part of this great event. And definitely, we look forward for more collaborative events and efforts in future. And I really thank Professor Alfred Kusheri, who came to all the way from Dundee to Bangladesh in 2018. Yeah, Professor, remember that, I believe. And we had a fabulous time.
I do indeed. I had
Yeah,
a
thank
very enjoyable memories I have of
right.
in Bangladesh.
Yeah,
Really,
we would love you to have again. I mean, to come to Bangladesh in future after Corona pandemic.
yeah.
So in this Corona pandemic, I personally wish you all safety and good health. And I really thank you very much, the president, the convener, the co-convener, and the organizers of this great memorable event. Thank you very much.
Thank you, Dr. Sardar Naeem. We have a brief video of the wishes from surgeons of Pakistan by the president, Dr. Farooq Afzal. Would you please play the video, Nitin, before we start the conversation between Professor Duwadia and Professor Kusheri?
Hi, greeting from Pakistan. My name is Professor Farooq Afzal. I'm President of Society of Surgeons Lahore, and I'm representing Society of Surgeons of Pakistan. It's a great privilege for us to, from the platform of Society of Surgeons of Pakistan, to endorse this joint communication or talk between two greats of laparoscopic surgery, Professor Udwadia from India and Professor Alfred Kusheri. And we all know that these are the pioneers in laparoscopic surgery. And I'm hopeful that we're going to gain a lot from the experience and insights of these people. We are looking forward with the collaboration with the IAGES and Society of Surgeons. That is going to improve the healthcare of the patients suffering from surgical diseases, and also to enhance the capacity building of our surgeons. Once again, I thank you very much for this great opportunity.
Thank you, Dr. Afzal. Now, what we do is we will start the video, and this is a conversation that was recorded 2 days back, where Professor Themten Udadia, our founder president, spoke with Professor Kusheri. And I regret delay in the start of the program today because of some logistical issues, but I wish you that you enjoy this conversation. Nitin, can we have the video, please?
We look forward to a happy 1 hour, 1.5 hours.
Will you start the dialogue? Professor Rudwadia, would you please start?
Sir Arthur, welcome to Mumbai. And I cannot welcome you to the IAGES because you're already a member of the IAGES. For that matter, you're a very elite member and honorary member of the IAGES from the last 24 years. You're perhaps one of the oldest IAGES members that go on today.
True.
I would like to remind you of the day you became an IAGES member. And you came to the conference in 1996, having operated on a minister of the government the previous day. You came to Bombay on the 6 a.m. You carried out all your duties, your lectures, you chaired a panel, you attended the inaugural ceremony, received your honorary fellowship, and you had to rush back to your important patient, catching the flight at 11 o'clock the same night. You were hardly in Bombay for 12 hours, but carried out every single duty you were supposed to do during the conference. And my son is standing next to you, waiting to rush you to the airport so that you catch your flight back to Dundee, Edinburgh and Dundee. So we are very glad that you exerted to the utmost to come for our first invitation, and you've always been with us in the heart all through.
I could never not have come, irrespective of the requirements imposed by me in operating on an elderly gentleman who was in a very important position in the UK. And if things had gone wrong, I was prepared to risk that. It's something I never did. That's why I had to leave so early from that beautiful congress, initial congress that you organized. It was difficult for me, but there's no way I was going to miss it.
Now, Alfred, they've asked us to talk of fond memories, but I think we can go on talking about that till the cows come home. So we do that for a time when we sit together over a glass of nice Scotch liquid.
Yes.
Okay. So I will go on to ask you a question I wanted to ask for a long, long time. In an age where we are in the grossly disruptive technology period, diagnostic laparoscopy was also disruptive because it brought about a new modality of diagnosis. And in the 1970s, I could count only 3 surgeons who were dedicated to diagnostic laparoscopy: George Bursey, Alfred Kushcheri, and myself.
True.
What to take on diagnostic laparoscopy?
I think diagnostic laparoscopy was actually a disruptive technology that never caught the limelight because it opened a new chapter. And without diagnostic laparoscopy, there would not have been minimal access surgery, or as others call it, minimally invasive surgery. I must say I prefer minimal access to minimally invasive surgery because to invade is absolute. You can kill a patient with a needle. As soon as you break the integument, the surgery you and I have developed is surgery designed to reduce the trauma of access. That is its intrinsic value. When I was training in Liverpool, they had incisions from the sifo to the symphysis. Good surgeons, big incisions. The number of patients as a training registrar had to rescue dying of pneumonia because it was so difficult and painful to breathe for these elderly.
This is the one most challenging moment of your life, and I'll tell you what is mine.
I think the most challenging experience, operative experience, is an invitation from the then president of the College of Surgeons in Edinburgh, who said, can we come to watch you in Dundee? That is the whole council, college, big people, president, watching me do a laparoscopic cholecystectomy. And as luck would have it, it was a very difficult one.
Always like that.
And I said at the start, I take no risk with the patients. And as an assistant to me, the fellow in my group was Les Nathanson. You probably met Les Nathanson.
I know him.
He was assisting, and he kept saying, oh, I think we should convert. I said, no. I said, we'll go slowly, and if I can proceed, we will convert. These people are in the audience, okay? And slowly by slowly, from what should have been at that time, the technology we had, sort of an hour and a half, took actually 3 hours to do a cholecystectomy. But we did it with a cholangiogram, and the patient was out the next day. So it shows myself that if you go slowly with a difficult case, irrespective of, you should forget everything else, but concentrate on your performance, and you have a living human being there, anesthetized, whom you must not harm. So if it takes 2 hours instead of 1, it doesn't matter.
Yeah. Can I tell you my most
Please do.
costly challenge? You see, Alfred, I had never done or seen a lab chole before. And you were kind enough to send me your, at that time there was a big box, like a chocolate box.
Yeah.
So I don't know what it was called. And you sent me that soon after you did your first. And the music, background music was fantastic. And it was Beethoven's Fifth.
Yes.
And the cameras were so awkward. But I saw that video about 100 pauses.
I think we've got a problem with
From the lessons we had when we started minimal access surgery. And what are your views on how we can make disruptive technology safer, more acceptable, and continuous?
what I can tell you is this, that in the years 1988 to 1991, in the United Kingdom, there was a tragedy with so many on-table deaths, usually from exsanguination, that I began to get very worried, especially that I had published the first 1,200 patients from the pioneering European centers in the American Journal of Surgery on laparoscopy. That's 1,000 from Germany, France, and the UK. I was the only surgeon. France, there were 3 people, Philippe Mouret, Périssat, and François Dubois, and 2 German groups, Troidel and Gert Busch, who's now dead, unfortunately. Troidel is also died last year, I'm told. So we collectively had done a register of 1,200, and with no deaths. Quite a high conversion rate, elective conversion rate of about 10%. We never took any risk. So when I went to the government to get permission to do, because we had to get permission from the DHSS to introduce it, I quoted this experience. And basically, I was confident that well introduced, this was safe. But I was wrong. Incredible the chaos in the back until something unfortunate happened. A patient who was the great friend of Lord Wolfson, House of Lords, very rich gentleman, was killed on the operating table. And he was a man of influence, and I wasn't. And he said to the government from the House of Lords, this can't go on. This is an indictment, not just to the surgeons that tended to it. This is an indictment to us governing this country. So he said, from my pocket money, I will give 10 billion if you, the British government, can fund another treble it to set up training facilities. And that's how I set up the Dundee Training Skills Unit. We spread eventually to 4 units in the UK, now there are 8, all right, which are funded by the government, and we have national courses. But to me, we were not prepared for mass diffusion of this technology because there wasn't enough trained people knowing how to do it. And the biggest mistake I ever did, which I will regret to my dying day, is to edit the films, to take out the bad bits, because that gave the impression editing video should not be allowed. That gave the impression that this is simple to do. Anybody can do it. So I was responsible for the initial tragedies. And a figurehead, and I published a paper researching on this. Yeah, that you will not, you should, when you publish a case, you have to publish it entirely without editing.
Right.
Well, I couldn't argue against that because that is so true. What I am, however, trying to stress is, and I know it's an exaggeration, that there are no such things as post-operative complications other than infections. All technical post-operative complications are enacted during the operation, are intraoperative. And if the surgeon is fully trained, he should realize this and say, this is not a good anastomosis, I have to redo this. And if he does that, and that attitude, now that's a mixture of cognitive skills you're talking about as well. But what I'm saying is, if it's not right, if it doesn't look right, if it's ischemic, if the anastomosis looks bad for one reason or another, you cannot just close the patient.
May I sum it up, Alfred, in one sentence? One of my mentors, Professor Baliga, said to me, which I've said for 50 years to each one of my residents: the time for post-operative care is on the operation table.
Agreed, 100%. If you want to know,
This is what Dr. Baliga told me.
Yes.
During communication.
Yeah.
You know, it's, and I've said this to every single resident for 50 years in every hospital I've worked in. The time for post-operative care is on the operation table. And then you don't have to.
I agree entirely. Entirely. Yeah.
Can we move on to something else, more personal?
Yes?
What, according to you, are the dreams that you have achieved? And what are the dreams that you feel are remaining to be achieved? You tell yours and I'll tell mine.
I believe that the dreams remaining to be achieved is a concept of mine, which I wrote about in an editorial 10 years ago, and nothing has happened. I believe that the whole concept of minimal access therapy will proceed well in the future when I'm gone. Only if we establish what I call disease-related treatment groups, consisting of interventional radiologists, interventional endoscopic surgeons, all right, and laparoscopic surgeons. So intervention endoscopists and laparoscopic surgeons. And this group should always be headed by a laparoscopic surgeon because he is the rescue option when things go wrong. So if somebody comes with a specific problem, this group of disease-related treatment group, it could be for gut, it could be for liver, it could be for pancreas, it could be for lungs, it could be for genital unit, whatever, doesn't matter, all right? They would decide, as we do now in treating patients with cancer, say, given the details of the case, which is the first line treatment here? Is it image-guided radiological intervention, usually for a complication? Or is it an endoscopic operation, nowadays probably, for example, for echinacea? Or is it a laparoscopic or minimal access operation that this guy needed, which is usually the case if it's a potentially curable cancer? I would like to see those groups functioning, these disease-related treatment groups. That is what I foresee. Well, irrespective of whether it's robotic-assisted laparoscopic surgery or whatever, doesn't matter. But in such a group, the surgeon has to be the top, guiding the group, in my view. And that is something that I think will eventually come. And let's put it this way, increasingly, operations are becoming interventions rather than operations. All right? They're becoming smaller in magnitude, in traumatic insult to the patients. Smaller. We are kinder to the patients as surgeons. But that is something that I think will eventually happen, particularly with the progress of the underpinning technologies that we will be able to develop further as humans.
Okay. Now I'll tell you what my dreams are and whether they've been achieved or not. You see, in the course of teaching diagnostic and therapeutic laparoscopy, I've traveled all over India, into small town and rural India. And my dream has always been that the quality of healthcare should be available to the poorest wherever. And the purpose of surgery is humanitarian. And if it is humanitarian, it should be available to all people in all places. And that is something I've been working for from the mid-70s. And Alfred, I have seen surgeons in rural areas sterilize their instruments in boiling water on a kerosene lamp, on a kerosene stove, and use those instruments. They have recycled their gloves so many times that they're full of holes. And I mean, I would, cringe to wear those gloves, but out of sheer embarrassment, I assist them. But that is what it has been. And now gradually we are seeing rural surgery grow to a stature where it is giving good surgery to people. And that is one of my dreams, which I've seen fairly coming through. Recently, we had the death of one of the biggest stalwarts of rural surgery, Dr. Tongaonkar. He was a great friend of mine, and we used to work together to bring up the standard, not of the rural surgeon, but of rural surgery. And today, it is an acceptable standard where good rural surgery is being done all over India. I would like the same to be done for good laparoscopic surgery being done all over rural India. That is something I will not perhaps see in my lifetime, but it is moving, and I can feel the thrust for surgeons to want to do laparoscopic surgery. For example, they're using mosquito net for laparoscopic hernia repair and making it a cheap hernia repair. So the thrust for spreading good surgery to rural areas, to tribal areas, is, I think, you see, we strut around in our tertiary thinking we are the cat's whiskers. But it is a rural surgeon who is the backbone of the surgery of the developing world. And I think it is our duty to look after them, their growth, their training, and their progress as part of our dream. And that, I think, is an important dream most Indian surgeons should try and cultivate.
I compliment you because it's a very laudable dream of yours.
No, I don't think it's laudable. I think it is necessary, Alfred. If you were to go and see a rural area,
you are an altruist.
necessary.
You are an altruist. Always.
No, I'm not.
Yes,
I'm pragmatic. I'm very pragmatic, Alfred. You see, if you were to go there, remember we went to see the Museum of Automobiles in Ahmedabad?
yes. Oh my God, I will never forget that.
Rileys and things. And wouldn't you feel that everybody should own that? If you go to rural India, you would feel that everybody should have good surgery.
I agree. No, I'm not doubting your premise. I am with you, all right, and I'm complimenting you. But
No,
you are an exceptional altruist guy.
No.
You think of others. Yes, you do. Well, anyway, that's my view, and you're not going to change it.
Anybody who plays golf can't be altruistic.
No. That's what I
Anyway, can we have one question before we wind up?
Okay.
What is your advice to the young surgeon who is coming up?
Irrespective of your position, always take good care of your patients because you are the treatment. If your treatment fails, the patient will be maimed or die. But it is your duty to ensure that your patient benefits from your intervention and care. Be a good doctor. Remembering, however, that there are no patients whom we cannot, as surgeons, harm. So beware of that. Keep that in the back of your mind throughout your practice.
May I give you what my advice would be? You see, like you, we've seen 60 odd years of surgical progress. When I was a house surgeon in 1956, a blood transfusion through those red rubber tubes was a surgical undertaking. The way surgery has progressed in the last 60, 70 years, I think the progress has been greater than what has been in all the millennia before these last 70 years. If somebody told us when we were in our 70s or you were in Liverpool that this sort of surgery is going to be done in your lifetime, you'd have laughed it off. You said, don't be ridiculous. How can this happen? And we have seen the progress that has been made. When 60 years back, we were doing simple surgery with basic instruments. Today, the surgery is mind-boggling that is being done. The equipment is really mind-boggling, out of this world equipment. But sadly, Alfred, what has happened? 60 years back, the surgeon could do no wrong. He was looked upon with respect, affection, and with great regard. Over the years, with better surgery, better equipment, the gap between the patient and the surgeon has widened so much that today the patient looks upon the surgeon with a degree of apprehension, even suspicion, which is very regrettable. At least it is in this country. And that is very regrettable. And the cause for that, I'm convinced, is the surgeon's greed. Splitting, unnecessary references, unnecessary investigations have made the patient ultimately aware that perhaps they are being taken for a ride. If the surgeon was to treat the patient as he would treat his father or his niece or his neighbor, I don't think this gap would exist. And I think one of the basic things I would advise the young surgeon is to get back to having this relationship with your patient, which is worth much more than any amount of money, because you sleep so happily knowing that your patient regards you with affection, with respect, and he gives you due reward. I think this is one of the main things I would like to teach or tell the trainee surgeon, that this gap between the patient and the surgeon has to be closed, and it can be only closed if the surgeon is truly honest, truly empathetic.
I cannot call you anything else but Prof, because that's the way we used to call you. Always, you will always remain that. And remember you with the pipe?
Yes. I gave it up, I'm afraid. I'll tell you this story one day. I'll tell you why I gave it up.
You can say it now.
Can I say it now?
Yes.
Well, I was treating a major hepatic injuries on the road to Dundee from Perth during winter, and this lady had severe trauma, required 30 units of blood by the time she came to surgery. And she made it. I think she made it not so much with my good intervention, but she was a strong person. And when I went to see her on the second post-operative day, not the first, she was too drowsy and on a ventilator. No, she had come off the ventilator now. Anyway, on that day, second or I can't remember, she recoiled from me. And I said, what's the matter? And you know, when you're very ill, you lose all your ambition. She said, Professor, you take so much of tobacco. And I was made to be so small. I said, I'm giving up pipe smoke. Yeah.
Well, it took a lady.
He's still alive, this gal.
That's amazing. That's a great story. That's a great
No,
story.
it's absolutely true. Yeah. You learn from your patients, you know.
Absolutely.
And it's
absolutely.
probably did me a lot of good to give up pipe smoking anyway.
Well, possibly you had smoked what you needed for your life by that time.
I know.
Yeah, but amazing, yes. And what's your routine, Prof, at this time? What's your...
Well, unfortunately, we've been in lockdown from the university since March. And it's likely that we will remain in lockdown the way that it's going in the UK, because of a big surge, second peak, for at least another year, so we're told. So it really has disrupted, because some of my research requires experimentation in labs and big expensive equipment. So we've not been able to do anything other than design and discuss, VR, these sort of Zoom and microphones, allow you to do something, but not to do actually experiments in proper labs, equipped labs. So it's been, to that extent, it's been very frustrating. On the other hand, it's given me the time to write a lot, and backlog of papers I knew I had to write, but was too busy to write. So I'm catching up. I think the secret in life is to occupy yourself efficiently with your time available. So, and as it happens, I don't sleep a lot. I only require a few hours. So I tend to work most nights really. Yeah. So there you are. But hopefully, I think personally, that's what I said at the beginning. This idea that we will beat COVID-19 is wrong. Even with vaccine, we will still have to live with this.
Absolutely. Absolutely.
And change our ways, we must avoid group functions and, reduce social contacts with big groups of people, and modify life. And in many ways, I think it's a time to think what we're doing to the human race and to our planet.
Very well said.
Perhaps good may come off this disaster. And I'm always optimistic, because humans are clever people by and large.
Yes, sir.
Sometimes they take risks, but they are clever. And I can't remember ever any illness that has not been vanquished by science. I remember when I was little, my whole class of 12 children at primary school got polio.
My goodness.
Except me, for some reason. I didn't. Now, whether I had something special, immunity, pulmonary, I don't know. But everybody, and they're all paralyzed. Some of them died with respiratory paralysis, few died but deformed and whatever, and maimed for life, basically. Nowadays, polio doesn't exist. I remember diphtheria that killed so many people, young children, doesn't exist. I remember more recently AIDS. Everybody said it's the end of the human race because it's affecting procreation of the race. It's vanquished. So I am not pessimistic, but I think the current reaction by governments everywhere, USA, here, India, everywhere, is the wrong one. People are panicking. They're not thinking about it rationally.
I think that's a very important point you made. We will need to learn to live safely with this, rather than stop work completely. Absolutely.
No option.
Prof, tell me, we at some of the large medical colleges, teaching hospitals have completely shut down because our hospitals are managing COVID patients. Do you think post-graduation training should be declared a null year and be extended, because that's a very big issue being,
I am convinced of that. We should take preemptive action now.
Yes.
You can, at the moment, you cannot train surgeons.
Yes, yes. I think branches which are hands-on, which are dependent on skills, they need to be.
All agree. I call them task. I call them task-based specialties.
Yes.
That requires a specialist doctor to
Yes.
do a task, an operation. All right, and those are you cannot. At the moment, you cannot. And so it's no use saying, okay, it's suspended. The training course is suspended until we have, that's what I meant, we have to adapt. There's no use fighting it.
Absolutely, absolutely. I think Prof. Udwadia is now joining back. I hope he's coming back with his video, so we'll just wait for him to come in. But yes, I think is there anything like that of we'll come back to you. So Prof. Udwadia, you are back inside.
I'll take a cup of tea sometime.
No problem. No problem.
Okay. So as I was saying, Alfred, that if we treat our patients right, like whenever I go for rounds with my residents, I tell them that the entire day of the patient has been the whole 24 hours. The key point is the surgeon coming to meet him.
Yeah.
And if the surgeon doesn't have time to talk nicely and pleasantly and make him feel good, doesn't have time to touch the patient, doesn't have time to make the patient smile and feel a little better before what he felt after he goes, you might as well not visit the patient. And I think these are the things surgeons need to come back to. How many surgeons actually talk to patients now? They just see their investigations. How many touch the patient? You see, I am convinced that the old surgeon who had the empathy of a surgeon, the humane aspects of a surgeon, is also equally important as the clever, hand-skilled surgeon of today. And to have a combination of the two would be the ideal surgeon.
I would agree entirely with that. Entirely, yeah.
Have you any questions to ask, Alfred?
Pardon?
Do you have any questions to ask?
No, I don't have any questions to say, except that I think we have to ensure that we have an open mind to future advances, but also have a way at national level of ensuring that any new modality of treatment is assessed initially in specified centers using certain criteria based on patient outcome. And once this limited evaluation in key centers, major centers, formulates the decision that this is a good surgical advance and reports in detail the results, that must precede any dissemination by any other hospital in the land. If we had that, all the problems we had when laparoscopic surgery was used by the likes of you and me would not have happened. If it was limited to a few centers who would be trained to do it by the masters, by the originators, before widespread, and the government, the UK, the Indian government had to bring in legislation that nobody, irrespective of seniority, can do this operation for the time being until it is assessed. That's what I would like to see.
Yeah, you know, Henry,
It won't, of course.
one of your predecessors, Sir Henry Ogilvy, said very aptly that please realize that every advance is not true progress. We have to tell the difference between an advance and something that is progress. And after evaluating the advance, only will we know whether that advance is really a progress or a gimmick.
Yes, yes, I agree. Hades Ogilvy was a very clever man.
Very clever. I love he's got some lovely books, one of which is No Miracles Between Friends.
Yes, yes,
Mayo Clinic.
yes.
Fantastic. All his books are wonderful. I collected all his books.
You know, I've never met another person called Hades like he was. His first name, I've never encountered it in any other person. Hades Ogilvy.
Yes. Yes.
Well, you know, it's a very unusual name.
I don't know how to pronounce it. I keep saying Hennig.
No, it's Hades. It's pronounced Hades.
Okay, I've learned something.
You know,
He's one of my models.
oh, well, I admire him or admire his writings very much.
And one of his best editorials was difference between physicians and surgeons. The surgeons play chess. The physicians play chess. The surgeons play other sport.
I didn't know that.
So it's an old editorial.
All I know that in one of his sayings, he said, every operation is good until it is found out. Those are as well, until it is found out.
And one of the sayings of Kurt Sem, the gynecologist under whom I trained for diagnostic, was that there is no safe laparoscopy till it is, no easy laparoscopy till it is safely over.
Yes, true. He was a great man. Kurt Sam was a great man. Yes, we were great friends.
So were we.
Yeah.
I was very scared of him because he took me in his boat and nearly drowned. And then he says, I'm taking you up in my aeroplane. And I said, no, I'm not coming up with you.
Yeah. It's a shame how his life ended.
Yeah.
His wife was so cruel to him.
One of the tragedies of a great man.
Yes. Ahead of his time.
How's Margot doing?
Margot is not well. She has very severe osteoporosis and she has back fractures. She's become an invalid, I'm afraid.
I'm so sorry to hear. Give her my regards.
Yes. Okay.
Are you still in your windmill?
Yes, here in my mail. Yes, I do. Sorry. Hello?
Yes.
I can't see you anymore.
I can.
Oh, yes, I can. Okay. Yes, I like the mill. We have big.
Send us a picture of your house.
Huh?
Send us a picture of your home.
I will.
Love to see that.
I promise you, I will. I'll send you as soon as we finish. All right.
Okay. It's been seeing you. It's been great talking to you. It's like old times. I only wish to give you a good hug.
I say yeah. You are one of my dear friends.
And we are such a good
whenever
group.
I see you, you make me feel happy.
Alfred, I got you as the advisor to the chairman, and I thought you'd follow me as a chairman of IFSS. What went wrong?
I don't know.
I was so keen that you should follow as chairman.
Right.
I became political.
Yes. Okay.
So we call it a day?
Yes, please.
Great.
Nice to be involved.
Thank you. As part of IAGES all over again. Please.
Yes, okay.
A lifetime member of IAGES.
Okay. Thank you. Lifetime member is a great honor.
God bless.
Bye. Take care.
Bye-bye. Thank you, sir.
Bye.
Bye, Professor Kusheri.
Thank you, Prof. Thank you, Prof.
Okay. Bye.
Bye-bye.
Thank you for joining us.
Thanks. Bye-bye. Thanks.
It is indeed a great honor for me to play the host along with Professor Pavnendra Lal sir. In fact, I should put on record the efforts taken by Pavnendra Lal sir to establish the connect, and then it was so systematic. Yet another important lesson, at least I have learned in the last 3 weeks or 4 weeks of communication, is the most prompt reply comes from the professor moment he reads the mail, and it happens within few hours your mail is received by him. The most crisp answer and the most responsive answer ever I heard from such a great teacher is from Sir Alfred Kusheri sir. It's been a pleasure in the last 3 weeks working on him for the recording, and also put on the efforts taken by Professor Udwadia sir for preparing the questions. And he was also keen in listening to us what IAGES exactly is looking at from him. It is most important, such a great teachers listening to us are taking a very clear vision what we expect out of them at this age. Yet another lesson learned, well learned, and we learn from the wisdom of this great man. Pavnendra Lal sir, you please give your closing words, then I move on to the vote of thanks with Dr. Ishwarmurthy sir.
Well, it was just overwhelming to, conduct this session with him, and reminiscent of the old times, 25 years back, how we got inducted into this training and into this career. And great honor and privilege to coordinate this on behalf of IAGES. I must thank the leadership, Professor Raman Goel, Dr. Ishwarmurthy, and Dr. Kanagavel for making this happen. Thank you very much indeed.
Thank you, sir. Thank you so much. Now we have one important agenda coming in. We could not get Professor Farooq Afzal sir online due to logistic issues, as we had logistics issues with Professor Kusheri also. Professor Farooq Afzal, are you with us, sir? We could not see you, sir. Can you switch on your video, please? Yes, sir. You can give a brief. Professor Afzal?
Hello.
Sir, we are able to hear you, sir.
All right. Good evening, and it's a great pleasure to represent Pakistan. Greetings from Pakistan. What a great show. I was unfortunate to join very late, but last 15-20 minutes, I really enjoyed the show. And thank you, Dr. Raman Goel and all the team of IAGES for arranging such a wonderful event. And I look forward that in future, we are going to have more such meetings and learn from these giants. I thank you very much for giving me the opportunity to talk. Thank you very much, Kanigav.
Thank you, Professor Afzal. Thank you to the Surgical Fraternity of Bangladesh and Pakistan for endorsing IAGES program for the first time. And in fact, the Surgical Fraternity of the IAGES also places the fond memories and thanks to the fraternity of surgeons at Pakistan and Bangladesh. We officially request our National Secretary, Dr. Ishwarmurthy sir, to propose the vote of thanks. Over to you, sir. Ishwarmurthy sir?
Yeah, thank you.
Yes,
thank you.
Yes.
My dear President, senior colleagues, ladies and gentlemen, I'm sure you all agree with me it has been a remarkable day in the calendar of IAGES Prime Time. It will be remembered for quite a long time. I thank our Professor Udwadia sir for the time, efforts, and he has taken in order to bring and make the dream come true, bringing the Professor Kusheri to us today. And I thank both the Society of Surgeons of Pakistan, Professor Afzal, and also Professor Naeem from Bangladesh for being here, for both for felicitation and also for endorsement. We request both of them, to send their members in a large number to our Indo-UK Surgicon on 15th and 16th October. I'm sure we'll have a wonderful show, sir. Please join us for this event organized by Pawan and his team. I really thank Docplexus for making this event happen, and I thank Kanagavel and Raman Goyal for all the efforts they have taken to bring all of us together for this memorable day. And let us all meet in a fortnight's time, October 15th and 16th, for the 2-day colorful event of academics. Until that time, I thank you from the office of IAGES. Thank you, IAGES, and thank you, everyone. Good night. Bye-bye.
Thank you, everybody. Thank you very much.
Thank you very much, everyone.
Thank you.